I think beyond lutetium-PSMA, as we say, it's going to be important. Beyond lutetium-PSMA is going to be that we have to work with a lot of combinations, as we have touched previously. The combinations will be various. We'll be combining different isotopes. It will be combining things like PARP inhibitors, which are actually making grounds into how we actually are going to treat. And then, of course, how we utilize hormonal therapy with targeted radionuclide therapy. So I think the combinations will be an interesting aspect, and those combination therapies will work better in a setup where you have the correct patients. For instance, if you look into a patient that have got neuroendocrine component of prostate cancer, which I think the neuroendocrine prostate cancers are not well searched. We don't search for them, and therefore we have a problem of resistance. So we have to start searching, and we are doing that translational work of trying to see how can we image the neuroendocrine component within the prostate cancer. So I see us taking a lead in that space of identifying patients with neuroendocrine cancer, and therefore using that combination or targeting them appropriately in that way. And molecules like DLL3 will be the one that at the moment are in the lead, and we're excited to have exposure to that. And then, of course, I see us also identifying, as I have said, PARP inhibitors, but we have access to both the iodine labeled as well as the fluorine labeled PARP. And so that, again, will help us to see which are the patients that should get olaparib, for instance, and which patients shouldn't. And then which are the patients that, again, can benefit from the combinations. So I also see us in South Africa being in a situation of then having a situation, because when you do surgery, you might want to explore something that might be a little bit crazy now, but going forward, we might want to explore that we might treat what we don't see, the micrometastasis, such as what we're doing in thyroid. When you are in thyroid, the surgeons will operate, and thereafter you'll ablate with iodine-131. There might be a little bit of ablation that might come in the future, and us utilizing actinium-225-PSMA, which is an alpha, which obviously travels a short distance but imparts high linear energy transfer. That strategy might actually be interesting going forward. But also, we shouldn't forget in identifying lymph nodes when we image. So us utilizing technetium, as I have said, that's going to be an advantage, although technetium is chiefly going to be utilized by people that are not having PET. But in this case of lymph node dissection, I do think that their work might be important and beneficial, because sometimes those nodes keep on coming back and they are not nice for patients to be taken care of.